Uh, Good evening and welcome all. My name is Viraj Lavingia. I'm a medical oncologist in GI division at HCG Cancer Center, Ahmedabad. And today we have a wonderful webinar on use of anti-EGFR for metastatic colorectal cancer. I sincerely thank Dr. Reddy for supporting this nice webinar. And today we are joined by bazooka of faculties, if I may say, starting with Dr. Namrata Vijayvarga. She is Chief of GI Medical Oncology at Fox Chase University, Philadelphia. And then we have various heads of the departments from various parts of the country, starting with Dr. Shyam Agarwal from Sir Gangaram Hospital, New Delhi. We have Dr. Amit Rotan from Manipal Hospital, Bangalore. We have Dr. Prasad from MIOT International, Chennai. And if you are seeing me, then you know there is no secret. We are always joined by Dr. Senthil sir, my senior, my mentor, my guru. Again, head of the department from Indo-American Cancer Center, Hyderabad. Hi, everyone. And in today's agenda, we have a talk of 20 minutes by Dr. Namrata Vijayvarga on use of anti-EGFR in various lines of metastatic colon cancer, like first line maintenance and subsequent lines. And then we have panel discussion led by Dr. Senthil. So without further ado, let me present Dr. Namrata. Madam, screen is yours.
Thank you so much, Viraj. I appreciate it. Thank you so much for including me. I feel honored to be a part of the group and present my slides, and I'm eager to learn from everyone, because obviously the last time I was a part of it, there was so much I learned about how things are different in different parts of the world. So I'm very, very, very excited to be part of this today. Thank you. So let's start. I'm going to pull this up. Do I have sharing privileges? Let's see. There I go. I do. Okay. Now let's do the. All right. Can everybody see my screen well?
Yes.
I guess. Perfect. Thank you. So I know it's 20 minutes only. There's so much to talk about. So I've only touched on like the big things that are there that I know of, I guess. And then, I'm going to talk a little bit about like a case. I always like to start with that to keep, bring back and, put it all together. And then we're going to talk a little bit about, the treatment options, and I'll touch on the role of EGFR in the resectable setting as well. So there's a case of this 46-year-old guy who presented with a typical symptom, which was concerning for a lower GI cancer. Basically, FOBT was positive because he had abdominal pain. And then the colonoscopy showed a mass in the sigmoid colon that was biopsy proven to be adenocarcinoma. This is his mass. Here you can see. And then pathology was consistent. He was mismatch repair proficient, elevated CEA. And then on the CAT scan, as you can see, he had multiple liver metastases. He had 5 that we can see here. We're going to come back to the case and talk more about it. This is not a discussion about what to resect, what not to resect. So we're going to leave it behind. We'll just use this as as an example of both of those settings. So we talked about what additional testing we need to do, biomarker testing. Obviously, we sent it up for expanded RAS testing, BRAF testing. He was MMR proficient, and he was not found to have, he was like wild type, like RAS, NRAS, as well as BRAF wild type. So how do we treat this patient? And that's where we're going to start talking about it. There are 2 ways to look at it. Is there a path to resection? Is there not a path to resection? And that sort of sometimes defines how we treat these patients. So a little bit about the biology. If you test for KRAS, previously we had KRAS, that's about 40%, the exon 2 mutations. Most of them were in the codon 12 and 13 of them. And then there's a smaller group of patients who have a KRAS exon 3 and 4 and an NRAS mutation. So the average, 50 to 55% of our patients actually are mutated. So there's about 40 to 45 that are wild type. And these are both predictive and prognostic, which have it's a questionable. Some studies say it's negative prognostic, some are not sure. And we all feel that a non-mutated status is obviously better because you have an extra line of treatment you can offer them. And it's sorry, okay. So there's a lot of drugs that have been approved for the management of colorectal cancer. As you can see here, there's all of these. We're going to focus more on these two drugs here, but there's a slew of them, and I cannot not talk about the others, because when you're talking about management of colorectal cancer, the biggest question remains is how do we sequence them, how we combine them, and so as to play the best game of chess. If you have like nine moves, how do I win in those 9 moves? So we all know, we all start with the standard of care therapy with FOLFOX or FOLFIRI. It really doesn't matter as much which one you start with. It's based on more I think geographic areas. People in US start with FOLFOX because they were left sour by the results of the IFL study and increased rate of death from irinotecan. But I think over the years, FOLFIRI is equally good and maybe a better one because it doesn't lead to neuropathy, but they're both very good frontline options. Then more recently, the TRIBE and the TRIBE2 study have shown that even adding irinotecan, so FOLFIRINOX sort of becoming the holy grail of all GI cancers. If you can see here, there's the TRIBE study had 500 patients that were randomized between FOLFIRI and BEV versus FOLFOXIRI and BEV, and then maintenance therapy. And there was definite improvement in PFS in the FOLFOXIRI arm, represented by the yellow here. PFS was 12 versus 9.7 months, and then overall survival was 25 versus 31 months, favoring the FOLFOXIRI arm. And then a lot of people question that, if you give FOLFOXIRI up front, what do you do later on? And maybe the effect is diluted by that fact. So they went ahead and did the TRIBE2 study, which was FOLFOX BEV. Half of the people got FOLFOXIRI BEV and the other got FOLFOX BEV. And then once they progressed, they got FOLFIRI BEV. And then they were looking at this PD2, which is PFS2, whereas you have first progression on the first regimen, and then you have another progression on the second regimen. And this was compared to FOLFOXIRI BEV maintenance, and then putting these patients back on FOLFOXIRI BEV at progression. The primary endpoint was the ultimate, when you progressed on both these combined regimens or the single regimen, which was the FOLFOXIRI BEV. And you can see there was definite improvement. The FOLFOXIRI BEV, which is denoted by the red line here, or the arm B, had improved PFS2 by about a month and a half, but it was statistically significant. Interestingly, response rates were better in that setting, which was 62% versus 50%. So, in at least in our practice, a lot of our younger patients, 46-year-old, if you remember my case, if there is even a questionable path to resection, or if the patient can tolerate it, we always like to do triplet therapy nowadays rather than doublet, based on the results of 2 studies suggesting similar results. Now, let's come to the topic that we are going to talk about, which is EGFR. So how EGFR plays a picture into all these areas. We all know that EGFR is a very important mediator or a driver of colorectal cancers. It activates 2 pathways, the RAS-RAF-MEK pathway, as well as the PI3 kinase AKT-mTOR pathway. And they all cross-talk between each other. There's a lot of talk about that if you have a PIK3CA mutated cancer and you have a BRAF mutated cancer or a RAS mutated cancer, which we have drugs against now, just targeting one pathway doesn't help as much because the other pathway gets activated. Similarly, if you have a HER2 targeted therapy and it really is not active if you have a RAS mutant cancer, it's just based on the picture here. If you have 2 pathways that cross-talk between each other, just blocking one when the other one is constitutionally active due to a mutation is really, questionable and may not add much to the benefit. Similarly, there's a story, about BRAF mutant patients, and because they're RAS wild type, they're mutually exclusive. Really, therapy doesn't help, and that is the study that Viraj sent a message about this morning. About it's been presented at ASCO this year, where they're trying to see the benefit of cetuximab versus bevacizumab as frontline therapy for RAF mutated patients, where really cetuximab doesn't make much of a difference. So then there's a lot of biologics that are being tried. I always get confused. Cetuximab is a chimeric antibody, so it's an X, whereas panitumumab, which is this other anti-EGFR drug that we have available, is a human antibody, so it's a MUMAB, and BEV is a humanized antibody. And it's important to know these differences because a human antibody has a much lower chance of infusion-related reaction compared to a chimeric mouse human antibody. So which is important when you're choosing patients for this treatment. So the benefit of anti-EGFR therapy in colorectal cancer was first reported by this NCI-CTG CO17 study, where they compared patients with a refractory colorectal cancer. Half of them got cetuximab, the other one got best supportive care. And previously they didn't know that this was a marker. So initially the study, but then later on they published the results based on their RAS mutant status, and you can see clear benefit, right? So if you are, oops, I don't know what I did here, sorry. Yep. Sorry, yes. So we have a RAS mutated study, and in the RAS wild type population, as you can see very clearly, there's a clear survival advantage of single agent cetuximab over best supportive care. So this study, laid the foundation of activity of anti-EGFR drugs in colorectal cancer who are RAS wild type. At least that time it was KRAS that they were looking at. Interestingly, this has become, it's a well-tolerated drug, anti-EGFR therapy. So for older patients, if you're RAS wild type, I typically start with this therapy more than anything else. Then there was, in this study, you had the wild type, as you can see, these are the numbers. Response rate was 13%. PFS was better. Overall survival was significantly better, 4 versus 9. Literally, the hazard ratio was 0.4 something. So it's definitely, it is an active drug in this disease. Now, the other drug on the market is panitumumab, and we usually quote the ASPECT trial from Price et al. About its being similar. There's multiple studies that came after it, but this was a study where half of the people got cetuximab, other half got panitumumab in the refractory setting for wild type metastatic CRC, and there was identical PFS and OS. So there was no significant difference between the two drugs. And interestingly, you can see the infusion rate reaction was with panitumumab was only 3% compared to 14% with cetuximab. So we used this study to say, obviously I pretty much use it to switch panitumumab for any cetuximab that I use based on these results and better infusion reaction rates. Now, when you look at the role of panitumumab in colorectal cancer in the wild type population, you have the PRIME study for the frontline setting, and then there's a second line study where there was this combination of FOLFIRI and panitumumab, where both of these studies showed a PFS advantage to using panitumumab. Before the panitumumab data came out, there was the CRYSTAL study, right? The CRYSTAL trial was the iconic first line study that was a practice-changing study for the use of cetuximab in the frontline setting. It was FOLFIRI plus or minus cetuximab in the frontline setting. It shares the name with my mentor, Crystal Denlinger. So I truly, it's a special place in my heart for that study. But they used irinotecan backbone, very significantly improved PFS and OS for that study. Sorry. And but the PRIME study was FOLFOX and panitumumab in the frontline setting. This was a study, simple one-to-one randomization of patients getting FOLFOX alone or FOLFOX plus panitumumab given every 2 weeks. The study had about 200 patients on each arm, I think 220 on each arm. And as you can see here, it is, 320 in each arm, sorry. And then when you see here, the panitumumab and FOLFOX, which is the blue arm, did better in terms of PFS in the wild type arm. In the mutant arm, it actually did worse compared to the FOLFOX alone. So it's not only, it's important to check for RAS before giving this drug, because if you do it for patients with mutant disease, you actually might harm them. Not only like it's expensive and you toxic, but it actually has a poor survival advantage too. So always in the wild type population, giving panitumumab FOLFOX had improved OS. The primary endpoint was PFS, which was statistically significant. The OS was actually not statistically significant for this drug in the whole population, but if you just take the wild type population, the p-value was significant here too. And I typically use this whenever it's interesting, the full theory, cetuximab had the irinotecan backbone, the FOLFOX had the panitumumab backbone. So whenever I use these drugs, just based on the data that I have, if I'm trying to be a purist, I like to use irinotecan with cetuximab. And whenever I use FOLFOX, I tend to use panitumumab. Obviously, if a patient has an allergic reaction, everybody gets panitumumab. Now, coming back to, if we had talked about the TRIBE and the TRIBE2 studies but in both of them, the biologic that was used was bevacizumab. What about if you have a tumor which is RAS wild type and you don't want to use bevacizumab, or is there data to use anti-EGFR therapy with triplet chemo? So this was a Wolfie trial. It was patients with metastatic CRC who had, but it's a small study, 96 patients that were randomized in 2:1 fashion with FOLFOXIRI plus panitumumab versus FOLFOXIRI alone. There was about 100 patients. This for wild type KRAS population. You see here the PFS was better for the arm that was using the panitumumab, but small numbers, none of it was significant, right? So even though similar PFS, the OS was much better when you had the FOLFOXIRI panitumumab arm, and hazard ratio 0.67. Again, both of these were not significant, but what was significant out of the two was the fact that the secondary resection rate, as you can see here in the full analysis, FOLFOXIRI panitumumab had a resection rate of 33% versus 12%. So 33% of the patients ended up getting resection versus only 12% in the FOLFOXIRI alone group, which is also confirmed by the response rates. As you can see here, 87% response rates with the 4-drug combination versus 60% with the 3-drug combination. I use this data mainly. I've not used FOLFOXIRI with anti-EGFR therapy as much yet. I probably used it in one patient where there was, a young guy, and if they could get the drug off if they get the tumor off if the caudate lobe shrink and could ablate it, there could probably be a path to resection. We tried, again, no significant OS or PFS benefit, but there was definitely benefit in terms of resection and the response rates which we needed. So we tried it for the patient. It's tolerated okay. There's definitely way more diarrhea than you would see just with FOLFOXIRI alone. But other than that, it is but it is available. There's phase 2 data, so you have some data to support it, and insurance was able to cover it because of that. Now, after the frontline therapy, we talked about frontline. Obviously, if you're RAS wild type, consider adding this treatment. How about in the maintenance setting? There's a lot of data about, Bev maintenance, CAPE-Bev, the Cairo study, or bevacizumab added to 5-FU. The data for anti-EGFR therapy in the maintenance setting is lukewarm, right? Cetuximab can be continued and is usually continued in the adjuvant setting, in the maintenance setting, but it is if you look at the panitumumab data, the Valentino study actually answered that question to some degree. Here, what they did was they had RAS wild type patients who were untreated. They got initial chemotherapy with FOLFOX and panitumumab in both settings because they were RAS wild type, and they only got it up to 8 cycles. At the 8th cycle time, half of the patients just went on 5-FU leucovorin plus panitumumab, and the other half just went on panitumumab. So it doesn't answer the question of what would happen if they didn't get panitumumab, but the question of whether should you continue 5-FU with the panitumumab was answered in the study. And interestingly, and I think it's probably related to the fact that most patients, they stop the therapy at 4 to 8 cycles too. You could see here that the addition of 5-FU leucovorin was definitely beneficial to the panitumumab. So you have here arm A, which was the panitumumab arm, had PFS of median PFS of 13 months versus 10.2 months if you only continued panitumumab. So it just word of caution, always try to continue 5-FU if you're giving maintenance therapy with panitumumab. But most people who start panitumumab or cetuximab as a therapy with first-line anti-EGFR and first-line chemo for colorectal tend to continue these drugs in the maintenance setting unless the patient's having really bad side effects from it. Now, this next part is about, we talk about the sequencing and the sidedness. That's how I put it, because they are sort of interconnected, because a lot of these studies have evaluated all that has been done in different ways. There was this very interesting paper that was presented by Dr. Vinook et al. And Kurvez et al. From a SEER database, where they found that the right-sided colon cancers tend to do way worse than the left-sided colon cancers. As you can see here, the right colon is like way down. The left colon and the rectum sort of go hand in hand in terms of overall survival. And then based on this data, there was a lot of studies going on with frontline therapy with cetuximab or bevacizumab, which one should be used first in colorectal cancer, which is RAS wild type. There were two studies, the FIRE3 and the CLGB 80405. The FIRE3 was simple, 1-to-1 randomization, FOLFIRI-Cetux versus FOLFIRI-Bev in RAS wild type. This was KRAS wild type at the time. And you can see here, this was the only study where the FOLFIRI-Cetuximab actually did better than the FOLFIRI-Bev arm. The median OS was 33 months versus 25 months in this study. They did present, everybody questioned why the difference in survival came after the first year and a half compared to initially, where these curves are sort of on top of each other. And question, was it the second therapies that they got? And there was a subsequent study that was published that there was pretty much no difference between, everybody who was on cetuximab, 50% got on Bev. Of people who were on Bev, 50% got on cetuximab. Who were on FOLFIRI, got on FOLFOX, was on FOLFOX, got on FOLFIRI. Everybody got FOLFOX in the second line. So there was not much difference, but still this was an interesting finding, which not a whole lot of people were able to explain. But this study suggested that maybe starting with cetuximab is the right thing to do. But then at the same time, the CLGB study, which was very similar, they allowed FOLFOX or FOLFIRI as the chemo backbone and added cetuximab or Bev. And in this study, there was no difference between the two, right? So PFS and OS were pretty much overlapping, 29 versus 29.9. Now you couldn't get better stark similarities than these two. There was no difference between the two in this study. So as a result, people concluded that maybe it didn't matter if you were RAS wild type, you did anti-EGFR first, or you did bevacizumab first. But then they started, and based on the data that had come from sidedness as to left versus right-sided, everybody went back and reevaluated these studies based on sidedness. So this is a sort of consort diagram. If you can see here, midgut, this review article did a very nice job at summarizing the findings of these studies. So the CLGB and the FIRE3, these were the sequencing trials, and there's another one, PEAK, which I didn't include earlier. But in this study, midgut primaries, basically think of it as the right-sided cancers, and the hindgut primaries are the left-sided cancers. So for the midgut primaries, for the right-sided cancers, anti-EGFR therapy was worse than the bevacizumab therapy. So 29 versus 13 months favoring the Bev arm. In the FIRE3 study, also the Bev arm was better than the anti-EGFR arm. So the right-sided cancers, Bev did way better than anti-EGFR in the front line. Okay. Now, then you look at the hindgut primaries, it was the opposite. The anti-EGFR arms did way better than the bevacizumab arms, 40 months, like unprecedented survivals they were seeing in the CLGB study. 39.3 months for the anti-EGFR arm versus 32 months for the Bev arm. Similar numbers were seen in the FIRE3 study, 38 versus 28 months. So you can see here that the left-sided tumors, if you have RAS wild type, our preference is to use anti-EGFR therapy in the front line, no question. The right-sided tumors, we tend to save anti-EGFR therapy for the second line based on the results of these. These are all, analyses that were done later on, not built into the study, but the extent of difference was so stark that I think has convinced the, I think at least the US oncology population about it. Now, then they also did similar work on the Crystal and the Prime trial. So, let's look at the Crystal and Prime, where they were just looking at anti-EGFR. Here in the Midgard primary, when you just compare it to chemo alone, right? Anti-EGFR in the Prime, actually the chemotherapy arm did better than the chemo plus cetuximab arm. In the Crystal, it was the opposite. For the left-sided, again, the cetuximab and the arm and the panitumumab arms were better. So for patients where we are not using bevacizumab for some reason, so let's say I cannot give the patient bev for whatever contraindication that may be, I still use anti-EGFR for both left and right-sided, because just the Crystal and Prime data was conflicting between the two. Having said that, it's not, I don't think that one could differentiate and argue that maybe it's not the right thing to do, but I think we need more data to talk before we talk about that. So the last part is about the EGFR rechallenge. That's where like all the fancy stuff is happening right now. And, the whole idea of that if you get RAS and EGFR therapy in a RAS wild type patient, what ends up happening is you have one clone that is RAS mutant, which is a very non-dominant clone. Because you eliminate all the RAS wild type clones, this clone actually becomes the dominant one, as you can see here. And as they progress, basically what is predominant is the RAS mutant clone, right? And how do they find it out? We have sort of improved our circulating tumor DNA analysis strategies so immensely over the past few years that ctDNA seems to be the holy grail and the answer to all our questions of the future. But still work to do that. But very elegant studies have been done over the years, which have shown that as you continue treatment, you have response, you lose all of the RAS mutation or the ctDNA from the tumor initially after treatment, and then at the time of progression, about 40, as you can see in the picture below here, most patients at progression who were RAS wild type tend to develop mutations in the RAS or the BRAF, or just mutations in the EGFR binding domain. Some in the HER2 amplification was another important way of how these patients, escaped the treatment. So now you stop treatment, and then what happens? So there's a lot of data coming up that you keep following them, you sort of lose that RAS mutant clone again, and then these patients revert to the basal type, which is a wild type. And because of this, there may be a benefit to re-challenging them with RAS, with therapy, EGFR therapy down the line. And basis of a lot of studies that are being done, the proof of concept study, the one that I usually go to, was the Cricket trial. This was a small study, 27 patients only, in patients who got treated with cetuximab-based chemotherapy, then got bev-based chemotherapy, and then had progression. They at least had to have 4 months of response to the second line treatment, because that's sort of the time they thought was needed for that tumor to revert back to the wild type population. And they were following it along the way, but they didn't make decisions on whether to put the patients back on treatment based on the results of the testing, the ctDNA testing. But what they found was in tumors that had reverted back to the RAS wild type clone, there was a PFS was about 4 months compared to who continued to have the mutant clone. It was 1.9 months. So it was just a proof of concept, right? You revert back to the wild type, you give them again, and these patients still respond. Now, based on these, there's a few studies that are being planned or being conducted right now. We've done FIRE, there's FIRE-3, there's FIRE-4 study, which is cetuximab irinotecan for patients who have prior FOLFIRI cetuximab. There's the Kronos trial, which is, we will, I guess, we'll see the results of this first-line anti-EGFR therapy for panitumumab at ASCO this year. Then there's this panitumumab irinotecan study from Japan, and again in the re-challenge phase. And then this is re-challenge, which is again similar studies. So a lot of studies being done. They have not been reported yet, but it's something to look forward to, and I think is going to definitely develop an area to look out for this disease. So I'm going to pause here. I'm going to look at there's some chat questions. Let's see. somebody wanted me to finish. Okay, all right, sorry. And then as we move along, so pretty much done here. So the this is for BRAF targeted therapy. There is definitely a role for cetuximab in the BRAF patients in combination with encorafenib, which was the doublet therapy. As you can see here, the doublet versus control was way better than the triplet versus control. So the role of EGFR therapy in combination is definitely, the BRAF target therapy has improved outcomes. Response rates are 25-20% in patients, and is definitely used in second line for all my BRAF mutated patients. So in conclusion, cetuximab and panitumumab are used. They are approved. I typically use them interchangeably. Skin toxicities are important. Cetuximab has an infusion reaction rate, hence I prefer panitumumab in a lot of my patients. And there's a lot of data coming up EGFRv challenge. Important thing is don't combine these. That's if you combine biologics together, that's bad and leads to bad outcomes. So I am going to stop here. And
thank you so much.
Thank you.
Oh, that was a fantastic lecture. I think the questions will take it during panel discussion.
Okay.
Right. So Senthil sir, we can start panel discussion. And if there are questions in the chat, I'll lead your way.
Thank you so much, Viraj, for asking me to do this, and welcome again, Dr. Namrata. We had a great time, I think, 2 months ago. So let's see if we can learn again enough from you, and then sharing all the knowledge that all of us have.
My goal is by the end of these series, you'll remember my name and spell it correct without actually looking at it.
Okay, whatever it is. So I think the talk was lovely. You took us through all the relevant things as far as anti-EGFR therapy is concerned. Now we'll discuss all of those things in the panel. This case is just like what you said, a backbone to do all the discussion. That's about it. It's a very common clinical situation that all of us would come across. A 52-year-old lady, a homemaker, EC fatigability and abdominal discomfort of 2 months, no other systemic symptoms. She's a known diabetic, well controlled though, no end organ dysfunction. Ultrasound showed multiple liver lesions. Colonoscopy showed a sigmoid colon growth. Blood work was normal. The CA was elevated. The other markers were normal. And this is a PET CT scan. That's the mass in the sigmoid, and you've got multiple liver metastasis. So as I said, this is just a case that we are using to discuss the issues. The biopsy was a moderately differentiated adenocarcinoma. She underwent a molecular workup, which showed that the RAS was mutant. All RAS testing was done. BRAF was wild type. MSI was stable. HER2 was negative. So let me start with the senior most of us all, Dr. Sham. Sir, would you want anything else done, or you're happy with this workup and we're good to go as far as therapy is concerned?
Any thoughts on liquid biopsy for RAS testing?
We are coming to that's the next question. So okay, we'll start with the first question.
I'm happy with the.
You're happy with the workup.
Right.
Viraj, HER2 is generally not recommended by all the societies and guidelines, but we all have now resorted to doing HER2 with the data that these patients are resistant to anti-EGFR therapy. What methodology do you use in order to look at HER2? Because there are various alterations that you can look at. You can have expression, amplification, mutation. We are still in our infancy as far as understanding these are concerned and how to target. So what methodology do you use?
So I use IHC, which closely tells you the amplification, which has been studied as a negative impact for anti-EGFR. The HER2 mutation so far have not been shown to be negatively impacting benefit from EGFR. So IHC is what I do. But if I've given a chance, NGS, which can give you copy number variations and amplifications, would be definitely a better choice.
So when you look at the expression, what percentage do you use as a cutoff to say that this is overexpression? of course, amplification, you don't routinely look for since you're doing an immunohistochemistry, because the Heracles criteria is a little different vis-a-vis the more recent criteria that have been used to enroll patients on these studies. They're moving closer to breast cancer rather than staying with Heracles. So what is the cutoff that you use in your patients, Viraj? Both to target it later if you can, and also to say that it's overexpressed.
So 3+ is where I say no anti-EGFR.
That's 10% cells, or is it 50% cells? Because the Heracles use 50% and the more recent criteria is, so it's 10%. So that's an important point. So now we've come to accept that 10% positivity, uniform membrane staining is good enough to call it 3+. Dr. Namrata, if you're using NGS for all your patients, is there good correlation between the amplification that you see on the NGS versus the overexpression that you get on immunohistochemistry? Because some of these trials showed that if you just have amplification, you're not having overexpression, these patients actually don't respond well to the anti-HER2 therapies later. So have you looked at correlation studies? Because I try to look at it, I drew a blank.
So I think that, you answered the question to this earlier already, that why are these not in the guidelines yet, right? Because of all of these things, we do not know much about it. We do not know, yes, what does overamplification on NGS? What does that mean? What does mutation mean? I think these are all questions that with time we need to answer better. And until then, I agree with what Viraj says. IHC-CISH is my only thing that deters me from not considering an anti-EGFR therapy by itself in these patients.
Great. So all of us accept that we will do HER2 by IHC, at least for beginners like all of us. Amit, can I bring you in here? Amit, you are more of an NGS person. So how do you use this information as far as HER2 is concerned to make therapy decisions? We'll come to the anti-HER2 therapies later. That's not the issue of today's discussion, but just do you use NGS or do you use IHC?
No, I think colon is a place where I'm still not doing that much NGS, at least at diagnosis. I don't think it's adding that great value.
Great. So, because some people want to look at PIK3CA and then say, if you're PIK3CA mutant, you're not going to respond to anti-EGFR. There's so much of information that's bombarding you, and then you have to work through all of that. But I think that's what oncology is all about today. Lots of information. Sir, Shyam, sir, let me come back to you. Would you want to do a liquid biopsy? It's very rare that we don't have tissue in colon cancer or rectal cancer at diagnosis, right? It's a rare situation. But leaving that aside, would you like to do both solids and liquids to begin with, and look at are there anything that predicts for primary resistance to anti-EGFR? I'm putting that question back to you.
Current practices, we are not doing liquid biopsy.
Right.
Yes, if you do not have the tissue, then it could be worthwhile looking at the KRAS mutation, because that is a bearing on the therapy, So if you're forced to, then maybe, we are talking only at the onset, right?
Right, at the time of onset, correct.
So now your question is predict for primary resistance.
Correct, because there are some studies where they've shown that you pick up some of these RAS mutations in the circulating tumor DNA, not on the tissue. This moves back and forth, isn't it? Sensitivity, specificity, which is the gold standard. So from that standpoint, because they've shown that some of these, if you pick it up on the liquid biopsy, they actually predict for resistance to the anti-EGFR. So you're slowly moving towards that, but not yet. So that's the reason this question.
Right.
I think, as I said, right, biopsy, you can only take off one area. If for a tissue, that's the whole, why liquid tumor and ctDNA becomes the holy grail. It answers the tumor heterogeneity question to a certain degree. And can that predict? I think, again, it's very much in infancy. I actually, if I have a patient who has a RAS mutation on a liquid biopsy test that was done, because, here, everybody gets everything done somewhere or the other. And then if you have a tumor which was a RAS wild type, I actually still consider giving them RAS-based therapy frontline, because there is no strong data to suggest that I should be doing it otherwise. So I agree. I don't think we should, even if you see this, it's not something you act on.
Right. It's purely from a research standpoint, not yet in the clinic. Excellent. So we will do all RAS testing. We'll do BRAF testing, we'll do MSI, that's very important, but we won't talk about it today because that's not the issue of discussion. HER2, very important, 10% uniform membrane staining, IHC is the gold standard. So let's reiterate that point. Dr. Prasad, This patient comes to you. What is it that you want to choose as therapy? So this is left-sided, multiple liver metastasis. Doesn't look like this will get to resection at any point in time. Bilobar liver studded with metastasis. Liver function is good. So what would be your choice of therapy? Dr. Prasad.
KRAS is mutant.
No, the KRAS is wild type. RAS, RAF, MSI, everything is wild.
Okay. But in the wild type, then probably we will be, since it's a left-sided colon, we'll be choosing more of an anti-EGFR treatment along with FOLFOX. It's much easier for us to handle than any neutropenic complications. So my preference in this particular patient would be to go in for a doublet with the FOLFOX with an anti-EGFR.
FOLFOX with anti-EGFR.
It was written as KRAS mutant.
No, I have written it. Oh, I'm so sorry. I'm so sorry. I'm sleeping. You're still awake, right? Sorry about that. I'm so sorry. So that should be wild type. I'm so sorry. Amit, your choice for therapy in this patient.
So I would say chemo plus anti-EGFR is what we would do. The only issue is which chemo. I'd say in the last 2 years, we do a lot of triplets. So I would kind of favor a triplet. That's what I would do.
Shyam sir, triplet, doublet.
Yeah, you already made this point that this patient may not ever go for cure. So that puts you off. Actually, So, but then let me say this.
Yes.
So even if there are multiple lesions in the liver, you just don't know how good the response would be.
Okay.
So if you're aiming for conversion, and in your heart you think, as a young person, then triplet could be, could be in order along with the EGFR.
So what is it that you want to do for this patient?
Well, I like to discuss, and if the patient is fit, why not triplet and anti-EGFR?
Why not triplet and an anti-EGFR? Dr. Namrata, and then finally, I know what Viraj is going to say, but then I will ask him some questions on that. But I want to take you, Dr. Namrata, triplet, doublet.
With triplet with anti-EGFR, I've been burnt a little bit by that. It's not as easy. FOLFOX Uri-Bev is much easier to tolerate than FOLFOX Uri plus Tentumab, because the diarrhea actually gets really bad when you combine them for whatever reason.
Right.
And so I actually think, in someone who has a tumor extent like this patient, I'd probably go doublet with anti-EGFR here. The relative benefit is not great with 2 versus 3. The quality of life is way more important. But I hear you. If someone's responding, not responding, maybe in 3 months would I increase? I don't know, but I probably would favor doublet.
Great. Viraj, we discussed this in March. You are a fierce proponent of triplet, whichever way you go, whether it's right, left, center, whatever it might be. I know you go in for the triplet. But I think something that we need to think about, Dr. Namrata has already touched upon it, is that if you look at the difference based on your Cremolini's meta-analysis, which gives you a 3-month improvement in overall survival, better responses, 10% better, which again, we saw the data just now, and at the end of the day, poorer quality of life. And if you look at the hazard ratio there, it's actually, to tell you the truth, pathetic. It's 0.82, right? So, if you're really somebody who's a go-getter and pushing to resection and stuff like that, I think it makes a lot of sense to do the triplet. But in a patient like this, where it's unlikely, Shyam sir rightly said that, you can never drop anybody up. Except for that small iota of doubt that you might have, what would be your real justification, Viraj, in a patient like this, minimally symptomatic, less likely or unlikely, in a patient like this, if you decided to go for FOLFOXIRI and considering all the toxicities, doubling of diarrhea, doubling of neutropenia, doubling of febrile neutropenia, is it really worth in a palliative setting is a question that we have to ask ourselves. So what is your justification there?
So what I do, I'll tell you that.
Yes.
I maneuver the dose of irinotecan. And I think so that has given me success, I would say.
Okay.
I do not find this doubling of diarrhea in my practice. I start with just 100 per meter square and slowly build up to 130 and then 150 if ever I reach that. And like Dr. Shyam sir said, I would never write off any CRC patient who is super limited. And I have had personal case like this with 30 liver mets, and we ended up with our 0 resection eventually. And fortunately, there was no cash or Kali, what we say. So for me, it is triplet plus anti-EGFR. No
Great.
doubt.
So you're saying that if it is liver limited, never say that you can't resect. So let's take a call later. So start with the most active regimen here and then reassess at a later point in time. Very good, justified to go through all the toxicities of a triplet plus an anti-EGFR. Dr. Prasad, do you see in clinical practice, there is some data showing difference in toxicity, sometimes a difference in efficacy, but do you think this is clinically relevant? Do you think this difference is clinically relevant between cetuximab and panitumumab?
Earlier, I had been using cetuximab, but then recent times I've shifted more to panitumumab for the reason of lesser side effects.
Okay, so you see that it has lesser.
Much better with panitumumab. I don't really see the diarrhea as a major complication. The patients have to be opening in between the chemo.
Okay, great. Amit, any difference you see between cetuximab and panitumumab?
Not really. So the whole issue always was talked about is the infusion reaction, which is much lesser with panitumumab versus cetuximab. But over years, we have really not seen that much infusion reaction. So probably I think both go the same way for us.
Correct. I think those significant, the significance of all those, differences, hypomagnesemia that you get with panitumumab is probably, at least whatever little I have seen and done, is probably not that very clinically relevant. You're not always worried about torsade the points and stuff like that when you see hypomagnesemia. Dr. Namrata, your views on whether these are interchangeable in practice. You did make a point on your talk, but what do you do?
Well, I actually think that in my practice, at least, the rash, whenever like panitumumab rashes come, it tends to lead to a lot more like florid and violaceous rashes than cetuximab by itself when it happens. So I've had patients who had like such bad rash that needed hospitalization or some problem with the panitumumab that I changed over to cetuximab and they did better. Having said that, that's a very, very small number of patients. The ease of administration with it, as I told you, if I'm using a oxaliplatin backbone, I go with panitumumab. If I'm using a irinotecan backbone, I go with cetuximab, based purely on the Crystalline Prime data. That's all. This just because that's how the studies were done.
So you're the purist, as you said. Right. So you will go based on data driven. Right. Excellent. So we did put this patient on a doublet plus panitumumab, and this is what happened. This is March 2015. And then this is March 2015, of course, and this is March 2015. These are the same scans. And then you see that in November, after 3 months, you see a dramatic response. That was the liver when we began, and that's the liver now. So excellent response as far as the liver is concerned. So we come to the question of, surgery versus not. So again, Viraj, we did discuss about this point in our previous, case, which we did in March. So bilobar liver metastasis studied, should we be thinking that just because 4 or 5 remain after all the therapy that you've given, knocking those 4 or 5 out is going to cure this patient? Is that correct? Or what is your approach when you're looking at a patient who started with both lobes studded and then ended up with 4 or 5 that's remaining, potentially resectable? What is your logic behind going and resecting this?
So that is the most important key question that you brought out. I don't use surgery for cure, quote unquote cure.
Okay.
I use this as another line of treatment, and there is no doubt whatsoever that getting R0 resection definitely improves overall survival. We have a lot of data. So even though I know this is going to come back within some time in the liver, I hope we had hepatic artery infusion in our country, which many countries in the US use, but typically for these patients who are high risk for liver recurrence. But yes, I would, if 4 or 5 are left, I would be tempted, and no other disease outside liver, I would be tempted for R0 resection.
Shyam sir, you agree with Viraj that if 4 or 5 are left out and you can use some modality, whether it is SBRT, whether it's RFA, microwave, whatever that might be, you should go and knock them off?
So, it depends what number of lesions in which lobe are left behind.
Okay.
Since the entire liver was studied, if, for example, the leftover lesions in the liver are 2 or 3, then I'm going to push my surgeon to go for, a right-sided hepatectomy. And if you have the sufficient left lobe of the liver, that you can always do RFA for those areas. So, I would certainly go all out for a possible cure if it is possible to do RFA and the surgical removal of all the lesions. Because as we understand, hepatic artery treatment, etc., are all palliative.
Right. Amit, and then I will ask Dr. Amrita. How aggressive will you be in a patient like this to handle the liver?
Yeah, I think these are patients where you actually should sit in a multidisciplinary tumor board and discuss it out with your surgeons and maybe with the other liver-directed specialists, because there is always that potential. There is always that group of patients whom you are aggressive, you can see that long survival. So these are patients I would definitely sit down and discuss. But again, I always say, probably we are not the right persons to take that decision. So we should not write off the patient and say, no, this is stage 4, that kind that we believe it's not going to happen. We've seen surgeons do some dramatic things. We've seen some liver-directed therapies being added and getting dramatic survivals. So I kind of think in these patients, we sit down much more nowadays. We involve all of these team members and then deliberate this patient, should we or should we not? But I would say definitely I would lean towards trying something for the liver.
Great. Dr. Namrata, I think Amit has made a very important point. I agree totally with him. How would you approach this patient?
I think Amit just basically, summed what I was going to say, that I don't think we should make that decision, right? We think, yes, everybody, I think every patient with metastatic CRC with liver-only mets or liver-predominant mets needs a surgical evaluation and a multidisciplinary discussion, right? It is sort of wrong to just us making that decision, good or bad. Like, I thought one patient was resectable. I told her, I think you're all resectable, but the tumor was like sort of encasing the whole hepatic vasculature, which obviously I didn't perceive myself. And then this patient went to the surgeon and then he was like all disappointed. This was early on when I didn't know much, but I think I've realized over time that I shouldn't be pretending to know it. I can give you chemo. This is the benefit. Go see what they can do and what else we can do to improve it. In terms of the hepatic arterial infusion pumps, we have it at we offer it to our patients. I'm not a big fan of it. I don't think that the HAI is better than our modern day chemotherapeutic options. But that's big. But we do it because it's fancy. Patients like it. It brings money to the institution, all that fancy stuff. But by itself, I'm personally, I'm a chemo believer in that sense.
So all of us are the same, I suppose. Nothing changes 15,000 miles away. Okay, so I agree with all of you. So I think all of us are on the same page that every patient should be given a chance, right, to survive longer, if not cure. So this patient was discussed in a multidisciplinary. Of course, this patient also had a contrast triple phase MRI, which is something that we always do in our patients after your PET CTs, because we find more when we do a contrast MRI, and then patients are then finally decided upon as to whether you should have some liver-directed therapy or not. So when we did a contrast MRI, it still was showing multiple lesions on either side. Most of them were still active. So after discussion in our clinic, we decided that we will not. In fact, the patient went to Mayo Clinic to get an opinion on whether hepatic artery infusion should be done, liver transplant should be done. That's the extent that patients would go to, and understandably, all of them are really desperate to, live longer. But, fortunately for us, everybody was on the same page, and then they decided that we should not do any liver-directed treatment at this point in time. Amit, maintenance therapy, not very easy in patients with anti-EGFR. You walk in the corridor, you can spot a patient who's on anti-EGFR therapy in contrast to BEV. So what's your experience and what's your take? Again, Dr. Namrata made the point that the evidence is not very strong. All phase 2 subsets. What do you do?
Right. I think that decision almost gets chosen by itself practically, because most of these patients cannot tolerate anti-EGFR after a certain amount of time.
Correct.
So in my practice, I normally do anti-EGFR for about 3 to 4 months. And then after I have got the response, I kind of, whatever decision has to be taken, we take it, and then we remove the anti-EGFR at least. It becomes very difficult to tolerate anti-EGFRs. But chemo, definitely, we do continue chemo. If I had started with folfoxiri, then I just remove the oxaliplatin and continue FOLFIRI. If we are on some of these we do a lot of ILFs as maintenance rather than just LF. But again, that depending on patient situations, we do that.
Right. Dr. Sham sir, what would you do, and how would you manage this, toxicity with respect to anti-EGFR? Of course, doxycycline, skin creams, and all of these are there. Have you looked at dose reduction? Because some patients have lesser side effects to dose reduction, but I see that most of them don't have any big difference when you actually drop down the dose. So what's your experience?
Yeah, I mean, you like to reduce. The issue of cost also does come in when you're looking at the treatment on a long-term basis. But the rash can certainly be managed with, Dalacin C, which is a fairly effective treatment to my mind for, reducing the rash. And if somebody is really troubled with diarrhea, one can certainly, reduce the dose of panitumumab if they can afford on a long-term basis. So, ideally, I like to continue all three drugs, 5-FU, and panitumumab. But if, toxicity is coming in the way, well, then we can get away without panitumumab.
So some maintenance is better than no maintenance. That's what we are saying. If your patient is fit and is able to tolerate something.
5-FU is always on.
Great. Prasad, what would you also
go with either 5-FU or sometimes switch it over to more easier to handle the complications.
Right. So this slide is just to reiterate the point that Dr. Namrata made during the course of her talk. There's no phase 3 data. In fact, none of these trials actually have a no maintenance arm at all. We're just assuming that some maintenance is better than no maintenance at all based on the BEV studies. But from an anti-EGFR standpoint, there are no studies which have so far shown that some maintenance is better than no maintenance. Viraj forwarded the Panama study top-line results to me this morning. It looks like 5-FU leucovorin versus 5-FU leucovorin, plus panitumumab. It looks like the addition of panitumumab seems to be giving you better progression-free survival, numerically better overall survival, but we don't know the statistical significance of that, is what Viraj had sent me this morning. Thanks so much, Viraj. But I think, quality of life, very important in these patients, especially when you're just prolonging survival, you're not curing these patients. So Viraj, what are your thoughts before we move on to the next thing? Maintenance, what would you do today?
So what I felt with anti-EGFR and especially panitumumab, that this rash and other toxicities like diarrhea, they tend to drop off after second or third month. That is what I find. And like you said, off-label, I have been using 4 mg per meter square, where only end up doing just 200 milligrams, and the efficacy still remains. I'll be very skeptical in reducing the dose of cetuximab because we have data to suggest incremental dose of cetuximab improves response, while we don't have such data for panitumumab.
Okay.
Like we had a 500 per meter square weekly dosing was better than 250 per weekly dosing for cetuximab. So no experience with cetuximab dose reductions, but for panitumumab, I think I have played enough times to know the actual dosing. And I would do 5-FU panitumumab to answer your question.
Correct. So that's what we did. 5-FU panitumumab, that was what was continued. CA dropped to very low levels from 117 that we started with, 6.21 during the maintenance. But lo and behold, as all patients do, liver lesions started showing up again. Evaluation after 4 months of maintenance showed that the CA started going up. LFT was still normal. You're starting to see some lesions showing up on the PET CT scan again. I know those were the other ones that were always there and starting to light up on the scan. So all the questions that we are, confronted with: restart oxaliplatin, grade 2 neuropathy, or change to irinotecan. This is now 4 months off the oxaliplatin. Is there any data for treatment beyond progression as far as EGFR, anti-EGFR is concerned? Should be changed to Avastin at this point in time? Sham sir, first you, and then Dr. Namrata afterwards. Oxaliplatin restart or change to irinotecan? Question 1. Continue panitumumab or change to Avastin? Question number 2.
Progressing on panitumumab.
5 you look over it. Yeah.
Yeah. So, the common sense simply tells us to change the entire protocol from, whatever you were doing to FOLFIRI with Avastin. And the other things are research, whether you want to do a liquid biopsy for KRAS at this point in time, etc., etc. So, but I think the practical thing is to go for FOLFIRI Avastin.
Okay, Dr. Namrata.
Yeah, I actually would do it because most patients have had prior oxaliplatin re-challenging, again, quality of life neuropathy issues, even though if you, for the Optimox, like you sort of were using the Optimox 2 strategy here, but they went back onto their initial chemotherapy, right? They went back to FOLFOX at progression. I personally think it is, I've been able to do that maybe 2 or 3 times because most patients still have bad neuropathy that it's like, all right, I cannot give you oxali at the same doses. I'll just use it later on. I'm not throwing it out of my bucket of drugs that are effective. Like I think I can use oxaliplatin again down the line, but I would also change to irinotecan just because 99% of the times the patient have neuropathy that prevents me from going back. If they had no neuropathy at all, I actually would go back to oxaliplatin to be again the purest, following what the study was done, how the study was done. In terms of the Avastin versus panitumumab, I would not continue panitumumab. The patient has progressed on it clinically. We're just that sort of is like wrong. I would probably change them to Avastin. And it would be interesting to, I actually, this is the setting where we do ctDNA testing. There's very encouraging data just to see what are the degree of mutations that we see on the Garden testing or whatever profile you use. And then when the patient progresses again, I tend to repeat it and see if I can, the whole idea of re-challenge and, you have some data like down the line when you have less options, can I rebring or reintroduce this drug again? The most times it don't allow it.
Okay, Amit?
Well, fully agreed. I think I would kind of do FOLFIRI Bev. Senthil, can I ask you a question?
Please.
So this patient you had, if he had the HER2 in the first presentation, what would be your first line? No, I want to know the first line.
My first line would not have changed as so the reason, Amit, is that first of all, we don't have data and we have a regimen here in case you are the person who's using triplet plus anti-EGFR. The data is showing that there's a 95% response rate. I do not think that substituting the anti-EGFR with an anti-HER2 therapy will get you any better there. So Viraj rightly pointed out that in terms of prognosis, we are neither here nor there. In terms of targeting the HER2, again, we are not too sure how to target it, when to target it, and what best to target it with. So with so many questions, without any solid answers, I wouldn't put my money on an anti-HER2 therapy upfront in this patient. If you are using triplet, you're getting to 95%. You can't get better than that. So that is my opinion on anti-HER2, Amit. What was your?
My question was not on the anti-HER2. My thought was, we keep talking of resistant to anti-EGFRs with HER2 positive. Are you confident enough of using the anti-EGFR first line?
Great. Okay. So I'm sorry, I didn't understand your question. So if your HER2, as we rightly said at the beginning of this, we would have substituted that anti-EGFR with an anti-VEGF drug there straight away. It would have been a triplet plus an anti-VEGF drug rather than using an anti-EGFR drug. I would not think of targeting the anti-HER2 in the first line at all for this patient. Viraj, what would be your opinion?
I agree, sir. Triplet plus Bev, first line, and then subsequent lines targeting HER2.
Excellent. Dr. Namrata, how do you handle HER2 since Amit has asked this question?
I actually, it's a very good point. We order HER2 testing, but most of the time we don't have it available when we start first line therapy. And we don't push for that because of the same reason that I don't think we have enough data to change our standard of care therapy based on the results we will get for the first line setting. I think my first line setting is, these are all emerging data. There was a lot of data, as you know, is this BRAF mutant patient, would you give them RAS targeted therapy or, would you give them EGFR therapy or not? It's the same, idea in general. And I don't think there is a ton of data to say one way or the other for these patients. Hence, I probably would just treat him as if I didn't even have that result available with me. Know that they're going to not do well, though.
Okay, so that's very interesting that you would disregard the HER2 results, at least for your first line therapy, and then use it later if you can lay your hands on some good anti-HER2 therapy, maybe.
And if you have a trial, right? Right now we are doing it for everybody because we have a trial for that setting. There's like a sort of anti-HER2 based therapy with frontline chemo. If you have a study, then it justifies doing it. But other than that, no.
I think your viewpoint is what is reflected in all the society recommendations also, I suppose, because people are not convinced yet that you should be dropping anti-EGFR off just because somebody had a HER2 that's positive. But I think that the data is accumulating, slowly, and I'm sure very soon we will probably change and say that if you got a HER2 that is positive, you would better be off without the anti-EGFR drugs rather than using it. So that's what I would think. The other question, Amit, let me throw this to you, because you are somebody who's who's done a lot of DNA, circulating tumor DNA. So let's say you start doing circulating tumor DNA every 3 months, and you see that the quantity of RAS mutations are actually going up. Would you do anything to stop? Because there's data to say that the rise in these mutations antedates radiological resistance or clinical resistance by nearly 4-5 months. So do you think that stopping this anti-EGFR therapy early, just continuing the chemotherapy or interposing your anti-VEGF therapy early, will it really make any difference? I know there is no clinical trial data as of now, but what would you think? Is that what we will do in the future if the titer starts going up? Stop your anti-EGFR.
So I don't think we are there yet to take those decisions. So it's not that we really have that many great options for our patients in metastatic setting. We only have these three drugs, 3 chemos and 2 targeted drugs. I would be sort of very wary of going by a report of a rising ctDNA level, saying that that's good enough to say progression. I would say if we have radiological progression, then it's fine. Then we switch, stop, change. But I would not take a decision on ctDNA, though it does make theoretical sense in trying to understand the disease biology, but not a clinical decision. I don't think we'll do that.
Great. So I don't think we'll do that. Dr. Namrata, before you go,
Yeah,
how are you using this information today in your clinical practice? Is it already in, or?
I think it's more academic at this point in time, right?
Okay.
Definitely what I check for clinical, the patient has clinically progressed, right? So I just do it to see, well, is the progression, what is the reason for this progression, HER2 amplification or something else that I could probably target down the line? Is it HER2 amplification? Some 3% of them actually have that. Some develop a BRAF mutation. So I think all of these are interesting things to look for, which can help me decide what I can bring in later on. And then for the re-challenge, if I ever am able to get so I think it's just trying to increase number of options. I would never do it to decrease because we only have a handful.
Great. Sham sir, yeah, go ahead.
So what is your question? If I understand. So
if you're starting to see that the mutations are piling up,
right,
the RAS mutations are coming back, would you stop your anti-EGFR early?
Correct. So let's get specific now.
Yeah.
You do the ctDNA and you find this patient was earlier KRAS wild type, and now under the pressure of panitumumab, the clone KRAS positive starts appearing.
Correct.
So this patient is failing on panitumumab.
Correct.
Right. So now we said we want to give FOLFIRI and bevacizumab. So if you look at the recent data which is being published, well, they've shown that with the use of an alternative protocol, 9 out of 10 cases will have decline in the KRAS mutant population.
Correct.
In 4 to 5 months' time. So that is the time to go for a re-challenge. That is as per...
No, you've slightly misunderstood my question, sir. That we will anyway do. My question is, will you stop your anti-EGFR early if you start seeing the mutations come up? I know everybody has said no, I agree with that. Viraj, yeah.
Sham sir, this is before clinical progression.
Before clinical progression, if you see that your titers of RAS mutation is going up slowly,
right,
would you change early or would you wait for clinical progression before you change? That's the question, not the re-challenge. We come to re-challenge later.
Right. No. I mean, we will not change perhaps. I think
very good. That's the correct. That's the point. That's the point.
There's no correct answer because there is no trial to that effect.
At this point in time, you have the correct answer.
I'll wait for the clinical progression to take place. But if you have a rising titer, you're tempted. So I think the trials will decide, but I think you'll wait. You'll wait. I think
Dr. Namrata said the right thing. So we will wait. We'll not rush into something. Amit made the same point. We don't have too many drugs to play around with. And even if you find a beacon or if you find a Heracles, let's not be carried away, because the median progression-free survivals are 4.5 months, right? It's not some 10 months and 12 months as you get in the first line. So we want to squeeze as much as possible with our first line, because that's the best line before we really decide to change. Yes, you might know some of these options that you're having in front of you. Great. Yes, Prasad.
Since we're dealing with the disease progression, how good are we to introduce a liver-directed therapy like a TARE or TARES in between? We really do not have anything clearly recommended on a liver-directed therapy. The timing or the sequence, how do we plan? But for at least this patient, it's more of a liver-directed, liver limited disease for the past 1 year or so,
Correct.
about a year.
Correct. So this is liver-limited disease that seems to be progressing again now, Prasad. As I said, there was a lot of discussion about TACE, TARE, intra-arterial, hepatic arterial infusion and all that. But at the end of the day, the decision was not to do it because, as I said on the MRI that was repeated more than a couple of times, we found that, bilateral, you would have probably, as Viraj rightly said, maybe pushed that survival a little bit. You might have prolonged that liver disease progression, but I don't think it would have made a big difference at the end of the day. But as rightly pointed out by everybody, if there was 3 or 4 that were sitting there and you want to knock them off, it makes a lot of sense, because that has got a greater likelihood of improving the overall survival, not necessarily cure. A small percentage maybe though. Okay, so we changed to FOLFIRI Avastin, tolerated well, evaluated with an ultrasound and CA after 3 months, again a partial response. Stopped irinotecan after 8 cycles and continued on 5-FU, LV, and Avastin. So these were the lesions that were at the end of therapy, and then now it is progressing again. So while on maintenance with 5-FU, leucovorin, and Avastin, after 3 more months, it progressed again. So FOLFOX, anti-EGFR, FOLFIRI, anti-VEGF, maintenance anti-VEGF plus 5-FU, leucovorin, progressive disease. So how do you get to the third line? I think there's no standard third line, though, trifluopyridine, tipifarsil, and regorafenib are the standard textbook third line treatments. But would you go there, or Sham sir, what would you do?
Yeah, this patient did get good benefit from the first line.
Right.
I think at this time, one can go for the liquid biopsy to look at the KRAS status. And if the patient is wild type, I think, and if the neuropathy is not an issue, because there is a reasonable gap, one can revert back to the original protocol, which I think would be a reasonable option.
Amit, doing the KRAS on the blood and then deciding seems to be a very logical choice. But let me ask you this question. So this patient has been off anti-EGFR therapy for nearly 6 months now. I would say nearly 8 months, right? As was pointed out by Sham sir and Dr. Namrata earlier, it's about 4.5 months, which is the half-life of the, the drug. And the more the half-lives, the greater is the likelihood that you're going to see that titer going down. So after 8 months, would you be tempted to re-challenge without doing the RAS mutation titers, or you would definitely want to do that if you're going to do a re-challenge? Again, I bring the point back saying that, you've got limited options in this disease, so you want to see if you can use these again rather than, throw it away. So that's the logic behind, because first line, good response, good duration of another line of therapy, very likely that the RAS mutations would have gone down. So although preferably do the RAS mutation and then re-challenge, would you be tempted to say, even if it is there, I would still likely want to go back to an anti-EGFR?
So I would say yes, the temptation is definitely there, right? So one is already, it's a clear-cut oxaliplatin re-challenge candidate. So that I would definitely do.
Absolutely.
And I would kind of think, considering the old history of how it went, we would definitely probably think of adding the EGFR directly. But going by what Dr. Sham says, these are ideal candidates for doing a cell-free tumor DNA and see what the situation is. But with clinical practice, we do think of re-challenge.
I think it makes a lot of sense to re-challenge. Viraj, you want to go through that cricket data and tell us that it makes sense to do the KRAS and then re-challenge, because there's nice data to say that those who continue to have that mutant level up had a PFS of 1.5 months or something compared to 4.5 months with patients who didn't have. So what are your thoughts? You would certainly want to do it. Also look at other mutations.
So yeah, there are two things. Do we do
Yes.
this in clinic? Yes, we do. The reason is liquid biopsy for KRAS, at least for the Indian labs, are not validated for colon
Absolutely,
cancer.
good point.
And Guardant is too expensive right now.
How much is it, Viraj? I think Amit will be a better person.
Guardant is around 3 lakhs, I think. So that's too expensive.
Okay.
But
Shyam sir, after Viraj, after
I
Viraj.
would also like to share that I have already made a protocol validating with one of the companies, and I would speak with you individually that I would want to do this within end of 2022. We will validate KRAS on tissue and liquid for colon cancer only. Once that is done, we have an Indian test. There is no doubt in my mind that one must show that RAS is wild type before you subject them to the challenge. Because like you said, if you have a mutant clone or any other mutation, the benefit was virtually nil.
Absolutely.
As good as
Shyam sir and then Amit.
So what I was saying was that the ddPCR for KRAS is readily available and it is quite reliable to my mind from different labs. So if you are just focusing on KRAS, then I think a ddPCR is fairly okay. But if you, of course, want to look for other mutations,
You're doing an NGS, then you have to standardize.
The NGS.
ddPCR, sir, there is no data with even 20 patients yet published. So
I think we should get that data. You're on the right direction, Viraj. You're on the right direction. So we are happy to help you if you want.
And finally, Senthil,
sir.
I think Dr. Prasad made that point. So this is only liver-limited disease.
Yes.
I won't be averse to, liver-directed therapy at this point in time.
Fine. I mean, it's that again is, as Amit rightly pointed out, on a multidisciplinary clinic decision. As we said, multiple opinions all over the world. Ultimately, you know what happens when so many opinions come all over the world. Ultimately, decision happens in Hyderabad rather than decision, from anywhere else. Amit, your thoughts on liquid biopsy, standardization, Guardant, and then we move on.
Yeah. So what we've recently started doing is sending out there's some one or two platforms with the lung cancer panel who has the KRAS in that, and that's quite validated for lung. So I think we are very happy with that report on the blood. So I'm kind of starting to do that for my patients when I can't afford a Guardant, of course.
Right.
And then I do definitely think of that.
Right. So whenever possible, NGS, if not ddPCR, if you want to re-challenge. But if there is somebody who's affording maintenance anti-EGFR treatment and re-challenge with anti-EGFR, I don't think affordability as far as a ddPCR or an NGS will be an issue at all. So do as many tests as you can and get all the information that's necessary to make the next one. But, if for some reason you're not able to test or not able to do, I think if you get a good response, good PFS, good second line, long period on the second line, there's nothing wrong in giving it another try. There's nothing wrong, not the best.
I disagree a little.
Okay, little. That's why I said not the best. I know you are disagreeing
People
already.
are willing to spend money on the drug.
That's what I said. I said that should not be a deterrent.
So they're very reluctant, to be very honest.
Absolutely correct. Absolutely correct. That's why I said for some reason, we don't know what that reason is. It's like not getting tissue on day one. I don't know what that reason would have been. I agree with you. Right. So this is the data that Dr. Namrata was actually showing. You can find out so many other things which you can probably target, though we don't know which is the best way to do it, but there's something rather than not having anything at all. So before we conclude, is there anything? I think we've exceeded by time by 20 minutes. So is there anything that, any point that Prasad, Amit, anybody wants to make before I wind up?
Pretty much completed all the first and second line data.
Shyam sir.
Question to Viraj. So your thoughts on a person who is KRAS mutant and or not mutant, rather wild type, and then you treat them, and then what happens to them subsequently? The KRAS study, which is evolving, the converters. Can you make a comment on that?
So in this case, so I'll just take this case as an example where everybody thought that using panitumumab in second line is obviously a wrong thing. Well, we have data suggesting otherwise. The GONO study, the Italian study, where this used cetuximab after cetuximab failure, as long as your RAS the RAS clones were wild type in your tissue, that was better than doing chemo alone. We have this data. So, and based on that, we have a GONO 2 trial, where they are going to study as long as at every progression, your RAS is wild type, you keep doing cetuximab or anti-EGFR again and again, and hopefully that should do benefit. One of the interesting studies that will come in this ASCO, and I just read an abstract today morning from MD Anderson group, is that the clones that these are developing are rarely at the first progression. They are usually at the multiple lines of treatment. So that data is coming in this ASCO from MD Anderson. And that made me very comfortable in, again, using EGFR. If patient has progressed on EGFR, just changing the chemo backbone. That is my take on it.
Okay, thank you.
So I think it makes logical sense to do that. But as I said, for a purist, you probably need some clinical trial data. So, interposing some therapy and re-challenging with the anti-EGFR is not a bad idea at all. It will give you a good break from at least the toxicities, if not anything else, is what I would feel. Because so far the data on continuing EGFR has so far been negative. And this liquid biopsy story is a more recent story and more based on retrospective data rather than prospective data. So for now, change if your patient progresses on an anti-EGFR when you have good data, maybe yes for the future. Very good. So with that, I will close. I think it's very important to get an adequate. Sir, okay, you want to say something? Okay, you're saying wind up and close. It's time for dinner. Adequate molecular workup is very important. The best line is the first line. So make sure you're doing the right things in the first line. Not necessary that you can do the wrong things later. Continue to do the best things even after. Data for anti-EGFR maintenance is not strong, but getting there. At progression, liquid biopsy picks up RAS mutations than tissue, more RAS mutations than tissue. You can also look at the other alterations that might come up while on therapy. There is a role for re-challenge plus minus chemo based on clinical factors. And as we said, liquid biopsy may be used to monitor resistance and to re-challenge. And that's at our door at this point in time. It'll very soon enter in, and we'll probably start doing it in our day-to-day practice. Thanks, Viraj. Thanks, everybody, for, as usual, a very entertaining panel, should I say. And good night. Take care. Stay safe. Should I... Viraj, back to you.
No, I think it's time, and I think so. We should.
Okay, you're saying we had enough for the day. So bye-bye.
Thank you so much.
Bye-bye. All right. Bye.
Bye.
Bye.